is going to be shown on the fetal acceleration, because when you have preplacental etiology, the fetal acceleration is going to be accelerating. Is it clear? When you have a preplacental acute fetal distress, meaning that it is coming from the supply of the placenta, it's going to be accelerating, meaning that every time that there is contraction, there is an accelerating fetal heart rate. It tells you that the etiology of the acute fetal distress is preplacental. Now, if the etiology of the acute fetal distress is placental, generally the fetal acceleration is going to be instead decelerating. Is it clear? It is decelerating. The fetal acceleration is decelerating, meaning that what? Meaning that before contraction, the fetal heart rate was high, but after contraction, the fetal heart rate is low, meaning that it is decelerating from before to after contraction. While in the case of preplacenta, it is accelerating, that is from before to after contraction, there is an acceleration in fetal heart rate. Is it clear? Now, in case of post-placental etiologies of acute fetal distress, when you have post-placental etiology of acute fetal distress, instead going to the accelerations is instead going to be variable. And please don't confuse this variable acceleration with variability. Variability is the best method by which you can diagnose acute fetal distress. Is it clear? The fetal heart rate is just an element that can tell you that there may be acute fetal distress, but it's not the best among the cardiotocograph. Is it clear? So the best among the cardiotograph that can tell you that there is acute fetal distress is variability. Is it clear? And this variability, that when we say that there is a variable acceleration in post-placental acute fetal distress, it means that before contraction, let's say in the first contraction, before the contraction of the first contraction, there is going to be a high fetal heart rate, and then after contraction of the first contraction, there is going to be a low fetal heart rate, meaning that one there is going to be a deceleration. And then the second contraction, what you realize that there is instead an acceleration, meaning that before it was low and after there is going to be high. In that case, it is a variable acceleration. This is why we can conclude that the fetal acceleration parameter can help you to know the etiology of the acute fetal distress. Is it clear? So that is the first element that was based on acute fetal distress, in order for you to understand the why meconium can be as a result of the acute fetal distress. And you have explained that still in acute fetal distress, you are going to have ischemic compensatory mechanism, where there is going to be a DI hypoperfusion, a GI tract hypoperfusion, such that there's going to be a reduction in the content of the GI tract. So it's going to be meconium that is going to be released. Also, now on the fetal abnormality of the acute fetal distress, or the fetal abnormality of the bed asphyxia, we need to know that there is also going to be meconial aspiration, which can happen as a result of the meconium. Is it clear? And when you have meconial aspiration, here generally you're not going to have all these signs. You're not going to have all these signs of the fetal variability acceleration, showing that there's going to be a fetal heart rate abnormality or a acute fetal distress. So when you have meconium plus no acute fetal distress sign before labor, is it clear? Before during intrapartum, when there is no acute fetal distress sign in intrapartum and there is meconial aspiration, you can just say that the Bell's asphyxia is coming from meconium, and there is meconium. They say that the Bell's asphyxia is coming from meconial aspiration. Thank you.